Hello. I am Ilaria and I'm a senior associate consultant at Aerodyne. And in this episode of Diamond Insights TV CAR-T miniseries, I speak to Dr. Joseph Mikhael, CMO of the International Myeloma Foundation and seasonal clinical trial investigator of multiple treatments in development, including, of course, many of the CAR-T therapies that are trying to break in the highly competitive but potentially incredibly lucrative world of multiple myeloma. So here's my top takeaways from the interviews. Firstly, the wider patient population of multiple myeloma will pose unprecedented access challenges for manufacturers who want to reach the community, and they should look to leverage the existing connection that exists between that community and autologous stem cell transplant centers. Secondly, while outpatient administration seems like a good way to reduce costs and widen access, a fully outpatient model in the community seems still unfeasible, at least in the short term. And lastly, allogeneic therapy and faster manufacturing are seen as the future of CAR-T, a way to democratize this treatment and maximize its potential. Continue watching to know more, and I hope you enjoyed the episode. Thank you for tuning in into this episode of Diamond Insight TV. And I'm Ilaria Coppola, Senior Associate Consultant at Aerodyne. And for who's watching, I'm joined today by Dr. Joseph Mikhael, Chief Medical Officer at the International Myeloma Foundation and investigator for multiple CAR-T clinical trials in multiple myeloma. Joseph, thank you very much for your time today, and thank you for joining us to discuss the commercial and competitive angles around CAR-T access and uptake. Let's talk about your area of expertise, multiple myeloma, which has been the hot topic at recent conferences like ASH. So multiple myeloma is a great example because there are huge patient populations, while at the same time new targets like BCMA that have shown great results. So we know they have a plethora of available treatments already. So could you tell us why is cell therapy such a big thing in multiple myeloma?
No, that's a great way to introduce the topic, Ilaria, because multiple myeloma condition in which we've had tremendous strides over the last decade. We've doubled, if not even tripled, the average survival of patients by introducing multiple novel classes of drugs, new proteasome inhibitors, monoclonal antibodies, immunomodulatory drugs, and even still using traditional chemotherapy with stem cell transplant. However, despite these advances and now even new areas of antibody drug conjugates and nuclear transport inhibitors, we still unfortunately have not genuinely cured this disease. Patients will inevitably become refractory to all of these different therapies, and most of them really at best can confer about a 30% response rate at that most resistant disease. Whereas as we're starting to see with new cellular therapies, the opportunity to double, if not even triple that response rate and to maintain it for longer. So the appetite for CAR-T and CAR-T-like approaches is very much there in multiple myeloma.
Right, thank you very much. And I guess something that's quite interesting on our end to look at is the difference between myeloma and lymphoma, where some of these CAR-T therapies have been on the market for some time now. So we know that the multiple myeloma patient population is considerably larger, and most patients are treated by community physicians who don't just have multiple myeloma patients, but a lot of other oncology patients, and perhaps may not be interested in experimenting with newer products so much. So how do you think this disconnect will be addressed, specifically in the current climate where we know because of COVID, sales reps can't exactly go out and train these physicians?
Yeah, there's a lot of complexity to that great question you just asked. I mean, technically, we have more patients with lymphoma than myeloma, but in terms of if we look at all of myeloma as opposed to CAR-T being only indicated in certain kinds of lymphoma, you're right, we have a large population. So that's point number one. Point number two is, unfortunately, these patients are older in general because the average age of diagnosis in myeloma is late 60s, mid to early 60s in the African American population. And then thirdly, as you nicely noted, that most of these patients are cared for in the community by an individual who cares for so many different tumor types that typically their myeloma practice is less than 5% of what they do. So having that connect is important. One of the things I think that will help in the connection between community oncologists and centers that can provide CAR-T is going to be the fact that there is already an established connection for many of these patients by virtue of autologous stem cell transplant being the standard of care. And we anticipate that most transplant centers will also have the capacity to provide CAR T. As to educating the community, I mean, that is a challenge indeed. A lot of this now, of course, has gone virtual, like our discussion today, and that is very helpful to people. But there is a lot of enthusiasm around CAR T, and I think it'll less be about the docs knowing about it and considering it. I think it's going to be more about the pragmatic ability of patients to go to a center where it's available. You know, as it stands now, we have a lot of patients that don't go to stem cell transplant, not only because they're medically perhaps ineligible, but also because pragmatically they would have to drive a long time. There's a lot of practical access issues, especially here in the US with insurance and the like. So I don't foresee that CAR T is going to be a blanket that covers every myeloma patient. I do think that it'll still, to a certain degree, be accessible to certain populations more than others, which is, of course, why there's also an enthusiasm for other novel agents like bispecific therapy that may leverage the concept of CAR T potentially more deliverable in the community.
Right. Thank you very much. And actually, one of my following questions was going to be exactly about this. So I'll go with two. First of all, you mentioned autologous stem cell transplant as the standard of care. But do you think that CAR T stands the chance of becoming the standard of care itself? Because we've heard the opinion that it might just be a boutique therapy for those, as you just mentioned, that are near the academic centers. And so the second part of my question is, do you think there are some strategies that manufacturers could put in place to facilitate patients having access to these therapies that are somewhat limited geographically?
Yeah, great question. So the first one, it's just too early to know the data. There are a couple of molecules that are now, or approaches that are being brought into clinical trial where they're bringing it much earlier in the disease course and potentially in competition with autologous stem cell transplant. You know, you're the champ until someone else knocks you out. So the transplant still remains, if you will, the standard of care and the champ. And so I think that is being questioned. Theoretically, in our minds, you know, earlier in the disease course where patients' T cells are perhaps more agile, as it were, and less beaten down and more active, that could really herald to us an opportunity. So it's theoretically interesting and exciting, but the Joe conservative in me remembers to say, let's wait to see if it can be proven. With respect to enhancing access, there are a whole series of features that reduce access to CAR T that could be addressed. And some of them include, perhaps the greatest one of them is, can we develop an allo CAR T where someone actually doesn't have to have their T cells collected, where that kind of off-the-shelf concept where we can deliver T cells, true cellular therapy, but not ones that we've previously collected from the patients and manufactured and engineered, ones that are, if you will, one size fits all to a certain degree that we can deliver a patient. So that's clearly one point. The second would be the time of the manufacturing. If indeed we are collecting T cells from patients, part of the challenge now is that delay in between that can be sometimes as short as 3 weeks, but typically 4 or 5 and maybe even 6 weeks. So in that period of time, in heavily pretreated patients, it may be hard for them to wait. And then, of course, the pure access of geographically where these are, and obviously in COVID days, it's a bit trickier, but are they going to be able to facilitate this process to not just be in certain very major high-end academic centers, but, you know, will this induce a greater interest in having more cellular therapy in smaller hospitals that may not have all the sophistication of a large transplant center, but may be able to be certified within cellular therapy? I mean, that's a longer term strategy. But I think all of those things will affect. And then lastly, of course, making better products will ultimately be the issue. You know, can we do this more effectively, more quickly, and more long lasting, where people may not have to go back for further therapies would make it obviously much more attractive.
Right, thank you. And something else that you mentioned that's quite interesting, again, especially in the evolving world of CAR T, is that price tag that you mentioned. We know that these are therapies that are the most expensive that we've ever seen in the world of therapies and treatments. And we've seen that some companies, some manufacturers are trying some alternative ways to reduce that price tag as well. And one of them is the outpatient administration. It certainly is allowed by some biological features of the product itself, but that is being praised exactly because it could lower those costs. So what's your take on outpatient administration, its risks, its opportunities, especially in a country as big as the US, right, where we might have very separated, geographically speaking, centers that are administering these therapies?
Well, that's a great question. I think there are a couple of things that mitigate that. I mean, first of all, we've tried to do this in stem cell transplant, and many centers across the country have a significant proportion of their transplant process now outpatient. I mean, the old days, we basically admitted everybody through the whole, at least, 2.5 weeks, sometimes even longer. And now we've considerably shortened that. So I think there is precedent for it. But a lot of that, secondly, is going to be mitigated by cytokine release syndrome. We are definitely getting better at both preventing it and treating it. But this is going to be, I think, a particularly tender spot as we move forward, because trying to do this in outpatient setting, trying to do it maybe in a more community-like setting, without that comfort level of knowing that we can safely deliver something, is going to be different. Even in the bispecific therapies right now, every patient gets admitted, at least for the first, if not the first 2 doses. So I think that there is a opportunity there, but it is somewhat limited. It's not like we can just move it all to outpatient administration. Not to mention here in the US, the complexities of insurance and coverage and how one defines outpatient based on not an inpatient, but are they in a hospital facility versus an outpatient facility, the facility fees. I mean, all these things, factor into it. The last point that I would like to make, though, about cost, which I do think is important, it doesn't by any means undervalue, no pun intended, this discussion. But one of the things we're seeing and experiencing with our patients, this one and done like approach with CAR T cell therapy is quite remarkable. I think of a patient I saw recently who's now 18 months post CAR T, who feels the best that he's ever felt in his 10 years of myeloma. As he likes to say, Doc, I have no chemo brain. I'm not on anything. I joke with him that he's on my favorite drug, nada, nothing. And he's doing well. And I just think that has to a certain degree be factored in when we look at the progression-free survival and how it's not an ongoing therapy. Although, as you know, other strategies they're looking at following CAR T with something else to maintain that remission. But of course, when we look at costs, we always have to look at the global cost, not just of the intervention, but what is it preventing? What is it compared to? How long is it effective, et cetera? But I'm hoping with time, with more and more products in the market and a greater demand for it, a greater supply rather for it, that may affect some of the cost.
Right. Thank you so much. And so 2 last questions. The first one is, what are you most looking forward to in terms of CAR T and multiple myeloma? Is it faster manufacturing? You mentioned allogeneic cell therapy. Is there something else that we've missed out?
Well, I think it's, of course, all of the above is always going to be my best answer. But one area we haven't talked about quite as much is as these next generation cars are being built, if I can say it that way, without stretching the analogy, the ability to molecularly affect the process to allow the CAR Ts to last longer, because we think that that's part of the nature, of course, of why patients relapse afterwards, is that the T cells so-called run out of gas. And so as we look at these new modalities to have the T cells persist and potentially bringing them earlier in the disease course, where these T cells are, if you will, younger, as we said before, more willing and able to fight. Is it fair to ask the soldier the day before they retire to engage in this big battle? Can we have soldiers earlier in the disease course, as it were? So to me, that's very exciting. But honestly, the most exciting part right now is to see response rates that we just haven't conceived of before. that, as I mentioned, are double, if not triple, what we have available for patients in the short term.
Joseph, thank you very much once again for your time today. And on my end, it's been so interesting to get your thoughts and perspective on how CAR-T access and uptake works today and will potentially work in the future. Again, I'm Ilaria, and you're watching Paradigm TV. Tune into our next mini-series with our last episode on CAR-T. And thank you again, Joseph.
Thank you so much, Larry. It's always a pleasure.